Abhishek has made my life easier by elaborating on the biomechanics and the anatomy of the components. So my talk will preliminarily deal with the design philosophies on the femoral and tibial implant sides. So what are the objectives of my talk? The objectives of my talk are to understand the key concepts of how the native knee functions, which has already been covered elaborately, analyze how different implant designs mimic, replicate, or attempt to replicate native knee mechanics and function, and understand the risks, benefits, and outcomes of the different implant designs currently available. So what is the talk preliminary based on? So what is the articular geometry, the ligament function and kinematics, and the risk, benefit, and key outcomes. So Abhishek has already covered this, so I'll just skip on. So now I've designed this slide on the basis of cruciate ligament articular geometry and the level of constraint. So if you classify the currently available implants, they're available as non-constraint, intermediate constraint, constraint, and totally or highly constrained. So if you consider the non-constraint, you have the bicruciate retaining, the cruciate retaining, the posterior stabilized, and the anterior stabilized CR. In the intermediate constraint, you have the medial pivoting knee, the anterior stabilized or the ultracongruent knee, and the bicruciate stabilized double cam knee. In the constrained or the semi-constrained, you have the constrained non-hinge or the LCCK kind of implants. In the highly constrained, you have the hinged implants in all their varieties. So just a brief slide on the natural joint line and TK. As already covered, they are asymmetric condyles. The medial condyle dips lower, the lateral condyle of the tibia is higher. So all the implant designs are currently focused on these philosophies. So let's talk about the implants that are currently available. The implants which are widely used, I'll be covering them in slightly more detail. So the cruciate retaining TKA, the articular geometry, the insert is a flat kind of an insert where the medial and the lateral part of the insert are identical. The ligament function, as all of us know, in the cruciate retaining TKA, we sacrifice the ACL and we attempt to retain or we completely retain the PCL. So there is absolutely no ACL function. The PCL is retained and we attempt to put it in a native slope. So the PCL regulates the flexion stability and controls part of the rollback. And it's generally flat inserts. So as I said, there are no rollbacks. Paradoxical motion because the ACL is absent and there is an anterior sliding because of lack of the ACL, and this is a non-pivoting type of implant. What are the merits? It preserves bone as there is no box cut, lesser chances of fractures, surgical time slightly is less, and the main proponent for CRTK is that the proprioception is intact as the PCL is retained, and so the patient feels that it's a more natural knee. What are the demerits? So if there is a tight PCL, it is very, very difficult to balance the knee unless you follow an algorithm. So if you retain the tight PCL and you attempt to keep that implant, there will be accelerated polywear. So what do we do in case we have to balance a CR knee with a tight PCL? We go for a sequential release of the PCL and accordingly balance. You can see in the diagrams, extreme left, you can see that the poly base plate has lifted off. As and when the PCL has been released, the poly sits down back on the tibia. So a loose or a ruptured PCL can cause gross flexion instability and lead to failure of the procedure. A very, very controversial paper from Mori et al. So it showed 90% plus survivorship in 15 years, but this was a single center study. Even though the authors have wide experience, these results could not be replicated elsewhere completely. The most commonly used implant today, the posterior stabilized or the PSTKA. What is the articular geometry? These are dished inserts. They are based on the cam and post philosophy. Both the sides of the poly are identical. There is absolutely no ACL function, no PCL function, but the PCL function is handed over by the cam post mechanism. There is more contact on the posterior quadrant in extension. There is more AP translation in flexion as there is no ACL, but there is a definite rollback as the PCL is absent, and in deep flexion, the poly does rotate and create a slight rollback, but there is no pivot. So what's the merit of a PSTK? It's very easy to balance. It's easy exposure as the ACL, PCL are completely removed. And as I said, there is a definite rollback. Even though it's less, there is a definite rollback. So what are the demerits of a PSTK? More bone removal as we are completely taking the box cut, less proprioception as ACL, PCL both are out, and one of the very common but neglected complications is the cam jump in deep flexion. What are the other demerits? So because the cam mechanism is present, there is a lot of post-wear and breakage and wear and tear of the poly, but because of the newer designs, the highly rectangular shape of the post has now been modified and it has been made a narrow, a smoother post, so the chances of post-wear are now less. Another very unique complication to the PSTKA is the patellar clunk syndrome, usually seen in patients who have a small patella, who have a big box, and who have a high box to flange ratio. And the same institute also published this paper comparing the results of PSTK, which showed more than 77% survivorship at 15 years. In spite of all these, PS knee still remains the most commonly and widely used knee because of the ease of the procedure. We'll come to the other slightly uncommon but better knees. So the bicruciate stabilized knees. The articular geometry is identical, the medial and lateral are equal. The anterior and posterior cam substitute the ACL and PCL. In kinematics, it shows a reduced paradoxical motion. The next kind of the knee is the anterior stabilized knee. The anterior stabilized knee has a CR insert with a high anterior lip. The PCL is sacrificed, but the knee is without a post and cam mechanism. The disadvantage, kinematic point of view, it has more laxity. Merits, it's a bone preserving surgery, more wear, less ROM, but definitely less rollback. New kid on the block, very widely used now, medial pivot knee, more congruent medially, less congruent laterally. Ligament function is substituted by means of articular geometry. Medial pivots in deep flexion. It is claimed to have better kinematics and is also functionally shown to have better kinematics. And the biggest merit, our point of view, is that these patients show better patient satisfaction. The newer kind of implants, the anterior substituting cruciate retaining implant, again, medial and lateral are the same. Anterior post substitutes the ACL, so the gliding of the knee is reduced. The PCL is retained, reduced paradoxical motion, but the outcomes need more data as these implants are newer. There's no study more than 8 to 9 years currently. Bicruciate retaining. Again, medial is equal to lateral. I'll just take a few minutes. Ligament function retains ACL and PCL. Gradual rollback, no pivot. Technically a very difficult procedure. There is a high risk of bone island fracture risk and malrotation on the tibial side as we have to preserve the tibial island. This knee comes very close to matching the kinematics of the natural knee. The biomimetic biocruciate retaining TKA, it retains ACL and PCL. At the same time, it mimics the natural kinematics of the femoral and tibial components. Technically difficult, bone island fracture risk as the previous implant and malrotation risk. But again, these implants need further research and further publications to see the efficacy of these implants. But theoretically, this comes closest to mimicking the natural knee. We'll jump to the semi-constrained knee. There is no axle. It's a non-hinge type of implant. Large tibia post and deep femoral box provide varus and valgus stability, and rotational stability. What are the problems? Because the post is big, it causes a lot of wear and breakage. There is high polywear, aseptic loosening, requirement of stems as a mandate, and may also require cones, sleeves, and augments depending on your case. And there is a dissociation of the components in long term. A small word on the mobile bearing TKA, the poly rotates on tibia, has equal survival rates compared to the fixed bearing. Problems of mobile bearing, it's a unique complication. There is bearing spin out as there is no rotational stability to the poly. You can see in the figure there is almost a 90-degree rotation of the poly. All polytibia, no modularity, no backside wear, similar function and aseptic loosening. Biggest advantage, low cost. Cemented TK. It's the current gold standard. It gives us rigid fixation from day one It is strong against compression but weak in shear and tension, and hence has a potential to loosen in long term. And there is a high third body wear risk, but there is good long-term data with high longevity. A word on the cementless TKs. It is made out of highly porous metal surface for ingrowth. The newer implants are made from titanium materials. There is early period of pain and micromigration before ingrowth of the bone. It's biologic, more durable, higher cost, no third body wear, high shear stress potentials, but there is no long-term data as of now. Monoblock tibia. The tibia poly is factory pressed onto the trabecular metal base plate, but there is no modularity, no backside wear. To summarize, this is a summary of all the implants that I have just discussed. So the bicruciate retaining, the ACL, PCL are intact. Articular geometry, medial is equal to the lateral. Bicruciate retaining, biomimetic, both are intact. Articular surface mimics the natural joint surface. I say mimics, it is not 100% identical. Cruciate retaining, the ACL is out, the PCL is intact. It is a medial equals to lateral, but it is round on flat articulation. Anterior stabilized CR, ACL, anterior cam post, the PCL is intact and medial is equal to lateral. Posterior stabilized ACL and PCL are out, congruent. Bicruciate stabilized ACL, anterior cam post, PCL, posterior cam post, medial lateral equal. Medial pivot, ACL is out, PCL is out, it's more conforming medially. Ultra congruent, the ACL and PCL both are out, but it has a deep dish anterior lip and hence it has enhanced stability. Semi-constrained, ACL is out, it has a tall post to match the PCL and medial lateral is equal. And last but not least, the totally constrained knee, ACL, PCL is completely out, it is completely based on the hinge mechanism and the poly sides are identical. I thank you for your kind attention.